thickleth. It's a poop stone. Because the stone is so, or the stool is so dehydrated that it literally becomes rock hard. And I have had patients who have coded and died because of that.
So is it just
because of vasovagal down. Yep. Okay. As far as the skin's concerned, as far as interventions, you guys, the next few slides, I would definitely like to highlight and be very familiar with these interventions. Okay. So integumentary, we worry about pressure injuries and things, so we want to make sure that we're using proper positioning devices to make sure that our patient's body stays in alignment. Okay. If we're rotating them onto their right side, we want to make sure that we're supporting behind the left, and vice versa. At least every 2 hours. If they are on bed rest and not getting up and out of bed, we need to make sure they have those compression stockings on, whether it's TEDS or SCDs, or preferably both. Okay. If they can't have those for any reason, they need to have some type of pharmacological, whether it's heparin or Lovenox, but something to thin the blood out to decrease their chance of developing a clot. Okay. Now it says maintain dry skin. I need to put dry, supple skin. We don't want them, soaking in water the whole time that they're in bed or anything, but we also don't want them to be, dry like the Sahara. Keep the sheets nice and wrinkle-free and dry, and of course, increase fluids to keep everything as moist as possible. Now that becomes a problem later if they're incontinent. But if they're incontinent, do we just let them sit in it? No, we need to get them cleaned up ASAP. Okay. All right. Here we have a person. I'm going to assume, if the picture changes. There we go. I'm going to assume it's a gentleman because of the amount of leg hair, but I don't want to presume anything. But this is what happens with those pressure ulcers when they heal. Okay? The skin gets discolored and everything else. But also too, this person is having a lot of muscle atrophy and contractures. So they can't bend their legs any further than where it's at right now. They can't stretch it out any further. They can't bend it back any further. It's basically frozen in that position. Okay? So I have two terms here that you need to be very familiar with. Atrophy, and in this case, we're talking about muscle atrophy, but it's loss of muscle tissue. Okay, so the density of the muscle itself is diminished. And then contractures is actually, it's still affecting the muscle, but instead of it being nice and pliable and able to move things, okay, it shrinks and it keeps that extremity in a certain position and they can't move it.
Is it possible for it to be fixed surgically?
How would you fix it surgically though?
I don't know, that's why I'm asking.
No. You would have to re-stretch that muscle.
For physical therapy?
Yeah, with physical therapy, yeah. Again, this is why it's very important to do what with your patients? Range of motion exercises. Keep those muscles moving as much as we can. They might not be able to run a marathon, but at least we need to keep their joints and muscles mobile. Okay, keep the joints lubricated, all that fun stuff. So encourage active and passive range of motion. What's the difference between active and passive range of motion? Active, the patient accomplishes the movement by themselves, okay? Passive is when we're the ones that are moving their extremities for them, okay? Then we have active passive range of motion, where they do some of it and we help with the rest of it, okay? Offer protein-rich diet to maintain muscle mass. Again, if they're not eating, okay, the body's going to need nutrients and it's going to start breaking down things within the body that it has the ability to break down. Anybody who has ever known anyone who is anorexic will know that eventually they will run out of body fat, but then the body starts breaking down muscle tissue for the protein. Okay? Assist client to standing position. Assist with ambulation is tolerated. We, of course, are going to do that with the patient wearing what?
Gait belt.
A gait belt, yes. Okay. Also, too, believe it or not, part of our job, therapeutic massage. Okay. Typically, it's just a back massage. but we wanna kinda, again, help that blood flow and circulation going through all the muscles, okay? If they have a DVT or at a high risk of doing that, you do not wanna rub the legs or the feet, because then you can cause that clot to move and possibly go to either the brain, the heart, or the lungs, but, so be cognizant of that. Cardiovascular wise, it's going to cause an increased cardiac workload, meaning that the heart is gonna have to work harder to keep circulation going, okay? Gravity tends to cause blood clots because it causes it to pool, which can then lead to edema in the lower extremities or wherever that is. Decreased ability to regulate blood pressure, so you need to be really careful with these people because they a lot of times will have orthostatic hypotension. Even going from sitting or laying down to a sitting position at the side of the bed for lunch or whatever, and they can literally pass out and fall and hit their head, okay? So be aware of that. SCDs, anabolic stockings. Now this was that machine that I was telling everybody about in lab last week. This is the SCD machine itself, okay? And it's got these long hoses that attach to those sleeves that squeeze and relax. And some patients like that. I did not. I was not a fan, but that's me. And let's see. It is 5 minutes till. Should we just go through and get out early?
Yes.
Yeah, I didn't think I'd hear a no with that one. And after I worked so hard figuring out how to make a slide with a time limit. Damn it. All right. Now, questions popping up. A nurse is caring for a client with anti-embolic stockings. Which of the following is true regarding anti-embolic stockings? Select all that apply. And for extra credit, if a response is false or not applicable, tell me why and correct it.
I think it's the circumference of the ankle, though. I don't think that's right. No. No, there's a lot of studies. In fact, you can actually get into, you can go into speciality for just fitting people for these. Yeah. But I don't think a prescription is required for anti-embolic stocking.
Yeah, those are true.
I do think it's EDC though.
What's up, Savannah?
Do we just say it to ourselves?
Well, I'm gonna wait till everyone's done. I
Okay.
evaluating.
I didn't know. I was like, I don't know if you're like waiting for someone to say something.
No. Has everybody got their answers though, at least? Pretty well? Okay, what about A?
False.
That's true. That's true.
What?
You do need to have a doctor's order to apply TEDHOs and SCDs. Because it is a form of therapy, believe it or not.
What?
Yep. All right, B, to select the appropriate size, the nurse must measure the circumference of the ankle. Where do you need to measure the circumference of?
The calf.
The calf. Okay. C, remove the stockings every 8 hours to assess the skin. True. Anywhere between 8 to 12 hours. Okay. D, they are used to promote venous returns, such as with clients with lower extremity edema. True. What else do we use them for? All of you guys should probably be wearing them so you don't get varicose veins.
Yeah.
Okay. And the stockings must be dry and wrinkle-free to prevent skin breakdown.
True.
Very true. So if you did A, C, D, E, You are awesome. All right, respiratory-wise, effects of mobility, okay? It's going to decrease the muscles that require to breathing. We really don't think about them that often because we don't have to think about breathing, right? When do we tend to think about muscle use? When you're working out, when you're trying to pump it up, right? Okay? But we have the interior and exterior intercostal muscles that help with breathing as well, along with what other large muscle? Your diaphragm. Okay, it's not just for pregnancy control. Different diaphragm. Okay. So we should position the client blank to allow for lung expansion to prevent atelectasis and pneumonia. What position do you think? Is it Fowler's? If we have a client having a hard time breathing and we want to increase their lung expansion, what was the position I talked about this morning?
Well, you do
Or
leaning forward on the
tripod or orthopnic position. Okay. Tripod and orthopnic position are the same. Okay? So yes, we're going to increase fluids, deep breathing, IS. How often should someone do their IS?
10 times.
10 times an hour, okay? While awake. Now, does anybody know what CPT is? What was it? Say it one more time. I heard you. I heard this. This is what I heard. And she's absolutely correct. It's called chest physiotherapy. Okay? I'm sure if you've known anybody with cystic fibrosis, the parents at least, sometimes get suspected of child abuse because they're having to bang on their child's chest to to move that thickened sputum up so they can cough it out. Okay? But what you do, and I'm going to borrow Ms. DJ here, or MJ, excuse me. I'm thinking Delgadillo, that's why I keep going DJ. All right. But you want to cup your hands, okay? And just and I would do this with my intubated patients when they were on their side while the other nurse was stuffing pillows or whatnot. Again, mobilizing those secretions, and even though they've got that tube down their throat, we can still suction them out, which you guys will get to learn how to do in a couple of weeks. Suction, okay. But that also, by moving those secretions out of the lungs, increases the amount of lung tissue that's able to exchange CO2 for O2, or O2 for CO2, whatnot, and help them breathe a little bit better. We do have vests in the hospital that we can put on these patients to do that as well, so that way we don't have to worry. So if it's a patient who has osteoporosis, obviously we don't want to be doing this, okay? Because it does take quite a bit of, you do have to kind of hit them kind of hard with it. That's why you want to cup your hand so it's not like that. But the vest basically is hooked up to air, and it shakes their whole chest and shakes the secretions loose to help them breathe easier. All right, gastrointestinal. Want to make sure that we have the patients with stool softeners. We do not, under any circumstances, really want our patients to have to strain or, okay? Why? What happens to your body when you do that? Some people pass out, okay? Or you get a headache, or you might feel dizzy, okay? That's called the Valsalva maneuver, is what that's called. You're vasovagaling down. That's why those patients with fecal lifts are such a problem, because they have that hard stool in there stimulating that vagal nerve, and it drops their heart rate and their blood pressure to the point of no return. Okay? So, specifically with our immobile patients, we do not want that to happen, so we have them on stool softeners to make it easier. Sometimes a little bit too easy. Sometimes they cough, and if you're at the wrong end of the bed, We want to make sure too that they're getting plenty of fiber, so all that fun stuff, and increase fluids to make it easy to go to the bathroom and move that stuff through. Okay. Now, as a general rule for nurses, when it comes to constipation, since we're on this topic, how long should we, or wait, how frequently should somebody have a bowel movement?
Once a day?
3 days.
I feel like 3.
Dude, dang! He's all twice a day. Like, yeah, right.
3 walk per week.
We grow concerned if it's been more than 3 days since their last bowel movement, okay? Because typically that means that there might be some stool sitting in their intestines for too long, and again, causing constipation, okay? That's why nurses are notorious for always, wanting to know, when was your last bowel movement, okay? And bowel care. It has a lot of repercussions. If you abuse your bowels continuously, it can cause issues. And by saying that, a lot of people who have eating disorders will abuse their bowels by taking excess amounts of laxatives so that the body doesn't have a chance to absorb the nutrients and things from the food that they intake, if they are eating, or if they're anorexic and things like that. So. All right. Let's see. We talked about that already. Now, ergonomics. We kind of talked quite a bit about last week in lab as well, and I want to make sure to stress this to you that again, communication is key when you are transferring or helping a patient move. Okay. You want to make sure that you yourself are keeping the center of gravity stable, because if you go and they're not able to tolerate standing on their own, guess what's going to happen? They're going to go down with you, and more than likely you're going to land on them. Okay? Face the direction of movement. I saw a lot of people last week in lab that were trying to do like this movement, or against where they were trying to get the patient to go. So you want to keep that nice and open. You don't want to be twisting, okay? It looks like I am, but I'm actually just, even now, my back is completely straight, and it looks like I'm twisting, yes? But I'm not. I'm just moving my weight from side to side, okay? Protect your back at all costs. If you have a back injury, you know what I'm talking about. If not, be glad you don't know what I'm talking about. It is not fun. Know your facility's policies for lifting and safe client handling. Some places do not allow staff to do a manual lift at all. Okay? So if your patient needs to have some assistance as far as standing up to get put in the wheelchair, they don't want you doing any of the lifting, even with a gait belt. They will have a lift that will get them from a sitting to a standing position that you then turn, and then it'll help them lower into a sitting position, okay? Or no matter what the lift is, you don't lift by yourself either. When it comes to working a Hoyer lift, now I know we don't teach you guys how to use them here, but you do need to know you never use a Hoyer lift by yourself. It should always contain you and another person, and I'm not talking about the patient. You and another healthcare worker that knows how to work that machine, okay? As far as lifting assistance though, if you're having to move somebody up in bed or anything like that, I do suggest that for every 100 pounds that your patient is, that you have another person. So even if they're 125 pounds, okay, you should probably have another person to help you move them up in bed, okay? We have lots of devices to help with positioning. This is called a trochanter roll. It's to help keep them up on their side. We typically have a tendency now to use a lot of pillows, but we used to have lots of wedges and things that we could just kind of put behind them to keep them up on their side. These are called an abductor pillow. You'll see these on patients who are recovering from recent hip surgery. They used to be in that for a good 4 to 6 weeks when they would do the full open hip surgery, but now they're able to do it laparoscopically, and so now they're usually in that for 3 or 4 days. The healing time is much faster than it used to be. Okay. We have splints that help keep things from going in the directions they're not supposed to. Ankle support devices, which we lovingly call moon boots, to prevent foot drop. You can also have your patient wear, even in bed, wear high tops to immobilize the ankle so that their foot doesn't pop down. Okay. Here's another example of some atrophy and some contractures. So it's not that he wants to keep his knee bent like that. The muscle itself has shrank and is keeping the leg in that position. Okay. All right. Now, we have a bunch of different positions that you do need to be familiar with. Okay? Along that one column where we have semi-Fowlers, Fowlers, high Fowlers, all that fun stuff, I do have a nice little cheat sheet for you guys to help you with studying. Okay? What I have is a picture of the position. There's a patient in that position, how it's defined, so sometimes with other terms that you might hear. Okay? How to help your patient attain that position. But what I want you guys to kind of work on, of course, in groups, is when to be cautious and what to be cautious of for patients in that position. Now, do you think I have left you with no resources other than what you know so far?
No.
Of course not. They're in the book. So make sure, and I believe it's page 1218 to 1219 in your rainbow book. So I'll pass those around. Take one and pass it around. So these are the most common ones that you'll run into. Over here are the lesser common ones other than orthopnic, okay? Trendelenburg. Well, yeah, it's like this, but where's the head and where's the feet?
The head is down.
The head is lower than the feet in Trendelenburg, okay? If your patient's crashing, they've got low blood pressure, all right? You're gonna tilt them backwards to get all that blood shifted back to the heart. Because we can't live without a heart. We can live without limbs. I would want to. What do you call a man with no arms and no legs in the ocean? Bob. What do you call him if he's sitting in front of your door? Matt.
What do you call when you see him underneath your tree?
Rob? No, what? You're sitting under your tree?
I was just making stuff up.
What about his twin sister in the ocean?
I don't know.
Oh, Duncan. Alright. Reverse Trendelenburg, it's the opposite. The head is above. The patient still has to be flat. In some cases, like when I had my cardiac cath done, I had to lay flat for 24 hours because they had put a big old hole right here in my groin to get up to my heart to put the stents in. Okay? About the size of a pencil, like this, right here in my groin. So if I went and bent it, pops open, and then I bleed to death. Not fun, okay? But the nurse was really good about it because they tilted my bed so that I could still watch TV without having to like look like this while laying flat and keeping my legs straight, okay? Then we have a modified Trendelenburg, which is a little mix of either one, okay? We do have, of course, the safe patient handling expectations. These are a couple of additional devices. This is kind of a gait belt, but it's got handles on it. So it's more typically referred to as a transfer belt because you don't really want to ambulate your patient wearing that. But it makes it really easy to grab onto the patient's midsection and not necessarily the gait belt itself, okay? Up here we have a toilet board which allows the person, and even independently, transfer themselves from the wheelchair onto the toilet, do what they need to do, and then be able to transfer themselves back. And then this lovely machine, anybody know? This is a Hoyer or mechanical lift, okay? That's the one that we can show you it, but we can't check you off on it, okay? Some facilities, like specifically in the ICU, we have lift blankets or transfer blankets, which are really nice. And it allows for multiple people to have like a handle to help move somebody up or to turn them onto their side and put pillows behind them. It's really nice, okay? All of these lifts, of course, and these assistive devices have weight limits, okay? Even the patient beds, like the ones we have, they have a weight limit. Typically, even the I don't want to say the cheaper beds that we have upstairs in the lab, the less modern ones, they can go up to about 600 pounds, and then they have to have a different bed, okay? A couple other things that you need to be aware of before I let you leave. Hot and cold therapy, okay? Now, you do not need an order for ice therapy. If your patient wants ice to reduce swelling or anything like that, you do not need an order for that. But you do need an order for heat therapy. So a heating pad, okay? You have to have an order for that. You want to be very careful in that you are making sure that there is a barrier between the skin and of the patient and the product, whether it's hot or cold. You want to at least have a towel between it because you don't want ice directly on there, because then what can happen? Frostbite. Not good. Okay. We want to increase circulation, not kill it off. All right, now with hot therapy, if you have it directly on the skin, what do you think is going to happen? You can cause them to burn, okay? Now, when would you use which one? For cold and hot areas? Who said that? You want to use the ice or cold therapy to reduce inflammation, because by exposing the body to cold, it's going to cause the vessels within that area to constrict and reduce the amount of inflammation. Okay? Sorry? You can use it for bruises, okay, or sprains, things like that, okay? When would you want to use hot therapy? You want to increase blood flow. Cramps. Ladies, correct me if I'm wrong, but when you're having that flow in, does a heating pad help or hinder? It helps. I can only take from what you guys tell me, because I've never had a period. I had two sisters growing up, and when I found my sister's tampons, I thought they were fun. I would throw them in the toilet. Of course, I was 4. All right. So safety precautions: never, ever take towels or blankets and put them in the microwave to warm them up. We have blanket warmers for a reason. Use those. If you have to wait 10-15 minutes for them to heat up, wait the 10 or 15 more minutes. Do not try to jump the gun, okay? You will set the hospital on fire. Okay, and I have lost count of the number of times that a code red or a fire has been called out in the hospital because somebody put popcorn in the microwave and walked away before it was done. Because they'll hit the popcorn button, which defaults to like 3 minutes, and usually the popcorn's done after like 90 seconds. So, yeah, not fun. All right, now, there's a concept map coming up, right?
Yes.
For fracture. This is the one time you all will get the same fracture, the same topic. You want to know what it is?
Yes.
Well, if you want to do the assignment, yeah. Hip fracture. Okay.
Does it do this Friday? I think
I think it's due next Sunday, not this Sunday.
It says it's due this Sunday.
Is it due this Sunday? Okay. Let's do this.
Are you
Sunday.
gonna change
Actually,
it?
I'll change it to next Sunday.
Okay.
Okay. You're welcome. Remember this at the end of the semester when you get to review me? Okay. He's awesome. He always was flexible to work with.
Is that one of the concepts?
Okay. So, with your concept map, make sure that one, if it's due next Sunday, that's my birthday, so you better have awesome jobs with your concept maps, okay? I don't want to have to sit there and like go over too crazy with you guys. There are a couple of things I do want to address with the concept maps, okay? Because I've been slowly looking them over, because I've been having to grade all those stuff for the communications class, which thankfully we're almost done with. When I talk about SMART goals, each goal has to be SMART, not a separate thing for the SMART part. You get what I'm saying? So each goal needs to be specific, measurable, attainable. Okay? What's R? Oh my God.
Relatable.
Realistic and time-worthy. Okay? Now, are you really going to wait 4 hours to see if a pain medication's been effective?
No.
No, okay? General guidelines would be, for anything taken by mouth, you need to follow up within 45 to 60 minutes, okay? If it's IV that you're gonna be giving, it's within 15 to 20 minutes after you have administered the medication. You have to go in and reassess to see if it's working, okay? I don't know about y'all, but my nurse gave me a pill and then didn't come back to check on me for 4 hours. Get rid of it. Okay. Any other questions, comments, concerns?
Is there any way you can send us like an example of how it's supposed to be for those SMART goals?
Well, we kind of worked on it at the beginning of the semester with that worksheet that we all worked on together. But I will put together a concept map for you guys this weekend. Okay?
And we
All
have
right.
appendicitis one due this Sunday?
Yeah, that one should be, and then this fracture one should be due next Sunday.
That's the one.
I just